Can make Rotarian Kalaimani as co-host.
Meeting call to order.
I request President Rotarian Hemlata Bandari to confirm the minutes of the previous meeting.
The minutes of the previous meeting were circulated on the group, and I hope everyone has read it. And since no queries and questions were raised on the same, the minutes of the previous meeting stands confirmed.
Thank you, President. Good evening, नमस्कार सभी लोगों को इस रोटरी क्लब ऑफ ऑर्गन डोनेशन की मीटिंग में बहुत बहुत स्वागत है। आप सभी का बहुत बहुत स्वागत है। फेलो रोटेरियंस और यूट्यूब के सभी दर्शकों का स्वागत है। आज की मीटिंग बहुत ही इंटरेस्टिंग है और वी हैव आवर फेलो रोटेरियन IPP Rotarian Dr. Gautam Goel, Consultant General and Endoscopic Surgeon, Director of Organ Donation Avenue of our District 3141 from Mumbai. And I request our Rotarian Manjeet Kahai to please introduce our guest for the evening.
Thank you. Dr. Gautam Goel is a consultant general and endoscopic surgeon with over 25 years of surgical experience. Dr. Goel completed his MBBS and then surgical training at the prestigious Lokmanya Tilak Municipal Medical College and General Hospital, that's Sion Hospital. While his surgical skills are vast, he holds a special interest in chronic venous disorders and diabetic foot care. Trained internationally in France and at the Doncaster Vascular Centre, UK, he focuses on modern, minimally invasive treatments for various veins and limb salvage protocols for diabetic patients. He has also been facilitated with a Lifetime Achievement Award by the Indian Poditary Association for his work in the field of diabetic foot care. Beyond his clinical role as a surgeon, Dr. Goel is a dedicated leader in the Rotary movement. He has served as the immediate past president of Rotary Club of Mumbai, Vadala East, and is actively serving at the Rotary district level this year in the Organ Donation Avenue. Thanks.
So welcome, Dr. Gautam, and thank you for sparing your valuable time with us and talking on the important subject of role of surgery in preventing organ failure, a surgeon's perspective. So over to you, Dr. Gautam.
Thank you so much, Rubiji. And Manjeet, thank you for this very wonderful introduction. I hope I can live my life in a way that I can make it kind of true to have received some of those accolades, not from everyone, but the respect that I'm receiving from you as well. So this is a very interesting topic. In fact, it's the first time somebody has ever asked me to speak on a subject which is, preventing organ failure and the role of surgery in preventing organ failure and a surgeon's perspective. And the moment I was given this topic by Lalji, I said, number one, thank you so much for giving me this opportunity. And I guess it also put me back into my thinking cap to try and figure out why and how I got involved in this entire process. So let me start. Let me try and give you a small brief and thoughts into what I was thinking about as I was given this topic and where it came through and how we would like to take it further. And before that is a very hearty congratulations to your group of Rotarians who've actually managed so much in terms of organ donation awareness. It's a process that I've been kind of partly affiliated with and have had a very small contribution over the last 25 years. And I understand how difficult this process is, but I totally have my hats off to you and my full support to you as well. So thank you once again to your Rotary Club and to our organ donation chair as well. And everyone who's tuning in tonight in the Gyan Live, whether it's Rotarians, our fellow doctors, or members of the public. or the members of the public. It's actually been an honor to be here and speaking on this topic, because it's not just professional as far as I'm concerned. For me, this topic is actually extremely personal. It takes me back to about almost 2 decades back when I was a young resident doctor. In fact, I was a qualified doctor at that time in general surgery. And my mother at that time was working as a transplant coordinator at Hinduja Hospital in Mumbai. And our dinner conversations in our house very typically were not routinely ordinary. She would come home and talk about patients whose lives hung in balance, about families which were being counseled through hardest decisions of their lives, whether to donate the organs for someone else, of somebody who was so dear to them and they had just lost. And she was part of that core team that used to work with people. She started off as a grief counselor, trying to understand people, and then she also saw a window in which where she could give them an opportunity to keep their near and dear ones alive in the future beyond their movement from this planet. And she was a part of the team where they had this amazing, where cadaver donation was relatively unheard of in our city, and there were very few that had happened. And then there was this young man, and whose mother had, kind of consented to give every possible organ. Unfortunately, this comes from a time when we didn't have facilities to accept the heart and lungs, but the lady says, "Take whatever my son can give to anybody else," and she was the hero, if you actually ask me, in that process. And those are the days when my understanding about those dinner table discussions had shaped my understanding about organ donation and that bridge between loss and giving a new life. But this influence also followed me into my own training. As a resident doctor in surgery under Dr. Madhuri Gore, I take her name because I hold her in immense respect from the Department of General Surgery. I had the privilege of being a part of the team that set up Mumbai's first skin bank at Sion Hospital. And I still consider it one of my greatest honors and my career that I was a trainee doctor, though I was a resident doctor, but I was the person who harvested the very first cadaver donated skin for that bank, skin that would go on to save the lives of burns victims who otherwise had no chance. That was the beginning of my own journey with organ and tissue donation. Today, I continue that journey as part of the Rotary Avenue for Organ Donation, working alongside your club, and other clubs where we try to create a lot of awareness and spread awareness wherever I can go about this thing. And I share this with you because, I want you to understand something before we go forward tonight, that the story of organ donation and the story of surgery are very deeply entwined, not just in my case, but just in terms of everyone. One is about giving life when an organ has failed, whereas the other is trying to, focus. What we want to focus on today is the surgery's quieter, lesser celebrated role in preventing that failure from happening in the first place. And that is where our mission actually is a combination, and we need to take it further. So, as a country, where do we stand? I mean, at the given moment, more than 5 lakh people in India are estimated to be waiting for a life saving organ. Some are waiting for a kidney, some for a liver, some for heart, some for cornea, some for lungs. And many will wait for years. Some tragically will not even get the chance to receive it on time. Organ donation is and will remain one of the most powerful acts of humanity, and it is literally the gift of life. And nothing that I'm going to say today is meant to diminish that message. If anything, everything I say tonight should strengthen it, because prevention and donation are closely connected. But here is a part of the story gets told far less often. A very significant number of organ failures are not sudden, unavoidable events. They are the end stage of a slow process, one that medicine and surgery could have often interrupted years earlier. And that is what I want to spend the next few minutes on, is the surgeon's role or a physician's role in starting well before anyone reaches an operating room for a transplant. So I want to surprise you with something, most of what I do is to protect a patient's organs. It doesn't happen in my operating theater. It actually happens in my consulting room, weeks, months, sometimes years before a surgery is even discussed. We don't just operate, we protect. It's a clinical assessment in the clinic, when the surgeon acts both as a diagnostician, as a preventive strategist, as a physician, because our patients rarely walk in, saying my kidney is failing. They walk in with a vague pain in the abdomen, mild indigestion or an unexplained fatigue. And it's reading those small, signals that the patient reaches out to, to us with. That way we actually start the prevention. This starts with evaluating that chronic hernia, which was manageable a lot of time before the person actually landed up with a sepsis and a complication of the same, a long-standing gallbladder disease where the patient has simply learned to live with that mild pain, or a recurrent urinary obstruction dismissed as just a constant infection. And when followed up well in the clinics, each of these people can receive preventable treatment, preventing life-threatening complications down the line. Two pieces of everyday clinical advice do enormous underappreciated protective work. Firstly is the NSAID stewardship, the painkillers, the diclofenacs, the brufens of the world. I routinely see patients on over-the-counter painkillers for joint pains, backache, period pains. In fact, it is so funny that when we ask them about their list of medication, these painkillers don't show up in that list of medication, but they're a constant with them. It is something that they pick up any which way. Sometimes their families are unaware of the fact that they're using it. And these chronic NSAID used in the leading is, one of the leading preventable causes of kidney damage. It also erodes the stomach lining, leading to perforations, maybe life-threatening sepsis in those situations. And all these things eventually lead to organ damage, across the body. So a brief conversation with them about safer alternatives, supervised time, time limited usage protects both the kidneys, the gut, and everything. Secondly is the blood pressure control before surgery. When we actually evaluate and we realize patients have blood pressure issues, some of them actually tell us that we were on blood pressure medication, we got okay, so now we've stopped. And we need them to realize that it's like that Woody Woodpecker syndrome, that woodpecker is going on knocking at something at small knocks that it gives it, and eventually it can even drop an oak down. So this blood pressure control is so important for us to protect the delicate microvasculature, not only of the kidneys but even of the heart and other organs, including the eyes, as we see it in the brain. So most of these in-clinic diagnostics and early referrals, whether it's for screening for endoscopy, to catch ulcers early, to catch polyps in the colon early, can prevent further conversion of these to malignancies and catch it early. Sometimes that evaluating your little stomach pain with an ultrasound could catch those gallbladder stones, which are actually blocking the duct and creating severe cholangitis over time, which eventually causes liver fibrosis and sometimes even pancreatitis, giving rise to a lot of multi-organ collapse within days sometimes, if not over months and years. And so this is basically what I wish to tell you. It's not the operating theater, but very often the clinic where the transplant list is actually kept short. Then comes the role of the operating theater and the surgeons, right? When we look at the kidney, and the kidney is one of the organs which is most in demand for transplant in India. And yet a large proportion of kidney failure doesn't begin with the kidney disease at all. It often begins with something surgical, sometimes a stone silently blocking a ureter for months, maybe an enlarged prostate causing back pressure into the kidneys, sometimes just a congenital structural variation where where there is a blockage which has never been picked up in childhood. And whenever we intervene early in these stages, we are protecting the kidney tissue, because once it gets scarred, these nephrons don't regenerate. And the kidney that we protect today is probably a kidney that someone is trying to keep off the dialysis machine 20 years from now. As far as the liver is concerned, the gallstones to cirrhosis-like damage, well, it's the liver is usually very forgiving because it's a regenerative organ until at one point it isn't. As a laparoscopic surgeon, one of the most common procedures I perform is a gallbladder removal for gallstones. Too many people, this feels like a minor surgery, but left untreated, gallstones can actually cause recurrent bile duct obstruction, chronic inflammation in the biliary tree, and long-standing neglected cases actually cause secondary biliary cirrhosis, a preventable route to liver failure. Timely laparoscopic intervention and maybe even open intervention in some cases, and can actually close that door permanently. Let's take it to diabetic foot, my own area of focus. This is so close to my heart because it's a large part of my daily practice. And India has probably one of the largest diabetic populations in the world. And the diabetic foot, we consider the foot to be another organ. Their complications is one of the most unrecognized paths to systemic illness. A diabetic foot ulcer is never just a wound. Left unmanaged, it becomes infected. Infection spreads to the bone, to the tissues, it moves up the thing, and it creates sepsis. And once there is sepsis, it's a whole body event. It does not spare any organ. I've seen far too often that a neglected foot with a small ulcer giving me a patient who walks to me into the ICU with multi-organ dysfunction in an otherwise stable diabetic patient. Early surgical intervention, debridement, vascular assessment, and limb preservation surgeries done before that infection turns systemic is what we normally try and do, not just to protect the kidney and the heart in the weeks later, but also their life at that point. A very basic thing like a varicose veins, often dismissed as cosmetic, can lead to chronic ulcers, constant pain, NSAID abuse, multiple antibiotics. All these eventually land up reaching you to a point where you have multi-organ affection, and all these small issues turn them into weaker organs. But while we talk as surgeons, I would also like to represent my brothers and sisters who are physicians in this role, because everything I have described so far assumes that a patient has already reached a surgeon. But by the time the patient reaches a surgeon, a physician has often already done the most important work of catching these issues and treating them, or may have missed a chance to do that because nobody has reached out to them. This is why sometimes routine health checks done consistently from the age of 40 onwards matter so much, whether it's your blood pressure, blood sugar, kidney function, your lipid profiles, liver function tests. They're inexpensive, they're quick, and most often they catch the earliest warning signs. And this is where we kind of can handle the patient who's on the borderline of diabetes from preventing them from getting into a diabetic process and getting further. And while we keep saying diabetes, I definitely want to speak to you about diabetes because it is the single biggest driver of organ failure in India today. It is fundamentally a metabolic disease. It damages the kidneys through diabetic nephropathy, the eyes through retinopathy, the nerves through neuropathy, the vessels through vasculopathy. And as we now recognize, it also drives fatty liver disease. In fact, what was earlier known as non-alcoholic fatty liver disease has now been changed towards a metabolic dysfunction associated steatotic liver disease, MASLD, the term which you'll often see. And very many who have probably got ultrasound will probably have a note sometimes saying grade 1 fatty liver or grade 2 fatty liver. And this is how this disease progresses, and it starts affecting the liver and taking it further. In the initial stages, it's very reversible, easy to catch, but once it moves further towards fibrosis and the liver moves towards cirrhosis, you are waiting then to move towards the transplant list. I'm going to go back to a surgical event, which is actually a small bridge between, it sits in that intersection between what I would probably call medicine and surgery, which is bariatric surgery. Bariatric surgery is weight control surgery or whatever you might want to look at it as. It's a trend of sorts over the last many years, but it's not just a trend. It's a very healthy trend that we are looking at, a little awareness that we do have options. And for patients who have significant obesity and poorly controlled type 2 diabetes, where diet, exercise, and all of the medications haven't been enough, bariatric surgery has increasingly got strong evidence behind it that it actually helps for genuine metabolic control. And a lot of these patients are actually kept off that transplant list by protecting not just their liver, their cardiovascular health, and everything else. It is not a cosmetic surgery, I must mention again, and it isn't a last resort in the right patients, but probably well chosen. It is probably a very important surgery in preventing people from getting onto the transplant table. So everything that I'm actually describing today, there's a pattern moving from the clinic to the operating table. What is important is that early, timely, and often minimally invasive interventions interrupts a chain of events that would otherwise end in organ damage. It's a real unglamorous world of prevention, actually, that doesn't make the headlines the way a transplant does, but the patient never becomes the next name on the waiting list. So don't ignore the basic preventive stuff because that is what keeps you off that waiting list. No problem is about to settle on its own. So pulling these two threads together where we look at, prevention and then we're looking at donation coming together, they're not competing messages. They're basically two ends to the same commitment of protecting life. Even when the best clinical and surgical care, there will always be some organ failure that cannot be prevented, genetic conditions, sudden trauma, extensive sepsis where we've lost control over how to manage the organism, and diseases that sometimes obviously present too late despite everybody's best efforts. This is precisely why organ donation remains irreplaceable. No amount of surgical skill or medical skill at that point can substitute for an available or a donated kidney in a patient whose own two kidneys have now failed beyond recovery, a person whose liver has gone cirrhotic beyond recovery. And prevention reduces how many people we end up needing a transplant, but donation gives hope to those who still do land up on that transplant list. Both saves lives. Both start with awareness, which is exactly why the platforms like this one, where we combine that prevention and organ donation together, have equal value, like yours. And that's why your platforms matter so much. So as we close, I'd like to basically have three simple asks. I just basically don't ignore the small stuff, is what I would say as a surgeon. The stone, the little ulcer, the swelling, the vein, the painkiller which you've been taking so often on without a second thought. An early consultation is not an overreaction, it is protection. Please remember that always. Second, get your routine checks done, especially beyond 40. Blood pressure, blood sugar, kidney, liver function takes 20 minutes, but it can probably add 20 years to your life. Third, talk about organ donation at your own dinner table, the way I was spoken to about organ donation by my mother, who used to work as a transplant coordinator. It did sensitize me to these issues. And then consider pledging your own organs as well. It costs nothing in life, but it can mean everything to someone else's family. So timely action, ladies and gentlemen, over delayed reaction is probably what we'd like to advocate. And that more than anything is what protects the organs for a lifetime. Healthy organs are precious. Timely care protects them. And when your protection isn't enough, donation gives someone else a chance we all hope for. Thank you so much. And I'd now be glad to take your questions.
Thank you very much, Rotarian Dr. Gautam Goel, for giving a surgeon's perspective about the organ donation, how to prevent organ failure from the surgeon's point of view. As you are also involved in organ donation right from the childhood, because as you said that your mother was a grief counselor and the organ donation coordinator at that time, and she was talking to the dining table. The thing which you have mentioned clearly states that it means that we require a prevention more than that knowledge of organ donation. The problem what we are facing, actually I am doing this for last 1 decade, more than 1 decade, that we talk about organ donation, but we are not talking about how to prevent that the organs should not fail. And that should start from the very beginning, from the childhood of a child, so that he or she will understand how to keep the organs healthy. As you rightly said, that if we will know the cause initially, like stone, you have mentioned about stone, and you said that the stone can be, if it can cause the liver failure, if it's a gallbladder stone or if a ureteric stone, it can do that kidney failure thing. So these are very small things, but people are not aware about this. Although in a personal note, again, I also was detected a gallbladder stone recently by my brother, as you mentioned. He's also a Rotarian Dr. Raman Goel. And I'm going to be operated on 22nd with a condition that 23rd is Sunday. So I have to attend the meeting of Rotary Club of Organ Donation International. So that is, so according to you, my question to you is, do you think that we should change our way of educating the people, like the government or NGOs who are only harping for the filling up the form for organ donation? And instead of that, we must clear the basics of why the organ is failing, so that the majority of the class who are not in that, who have not reached for the organ failure stage, they can be prevented. Instead that we will be only doing the things for those who have already reached to the stage and trying to educate about organ donation. What do you think about this, Dr. Gautam Goel?
So I think this is a fantastic question, Rotarian Goelji. It is something that actually came to my mind, Frank, when you asked me to speak about the role of surgery in prevention. And we always did, but I didn't think of it as separately as being something which was so corely tied up with that entire mission of organ donation as well, because the mission is not organ donation. The mission is saving a life. And and saving a life can happen way before we need somebody's organs donated to us. So I think it's a process. It's the mission is more about saving a life, whether it is through organ donation, whether it is through self-preservation. I think it's a message that can go together. So it is a message that can move together. In fact, whenever we do have a talk or an awareness program about organ donation, we can always add those two lines: please preserve your organs because they're precious. And by saying please prevent your organs because they're precious, it's also about your health, and it's about people reaching. It's like very often I tell my patients, I said, when you lose your consulting to me with no faida is probably the best faida you've actually had. Wasting your doctor's consulting fee is probably the best spending of that fee. You don't want to vasulo those things. It's like insurance. Jitna mera insurance ka paisa waste ho jaye, I'll be happier, right? And so it's extremely important that we do promote organ preservation, health preservation when we promote organ donation, and that's a very valid and important point, and we should do that.
Okay, thank you very much. Now I am opening the forum for the questions to be asked by our esteemed members. Whoever wants to ask a question, please unmute yourself. And yes, I can see Rotarian Professor Dr. Sudhir from USA wants to ask a question. Yes, Professor Saran.
Thank you very much. The question which I have is, there are two ways for me to live. One is responsible, cautious, and sensible living. The other one is reckless living. Listening to you, this thought came to me that the first one is better, and I will have my problem solved by the general doctor level itself. Nobody can claim every day will be healthy day. God is not that kind, and we are not that fortunate. But if my problems are resolved just at the physician level through my life, I'm fortunate, or particularly once I cross the age of 40 years. But then some people live recklessly, and then they reach the doctor late, and the doctor has no option but to push me to a surgeon, and surgeon can do very little if it is very serious case. So what I want to know is, what can we do as Rotarians here to make people resolve the issue at the moment when I can, save a lot of trouble for myself, not end up in a transplant situation. What all can we do?
So great. Sudhirji, thanks for that question. I think one of the biggest issues we need to work over here is at some point of time, even we have been younger. There was times when we always talked about जो भी हो जाएगा देखी जाएगी भगवान ने किस्मत लिखा हुआ है, all those kind of things that tend to happen. And very often I talk to people and patients also when they speak kind of देखा जाएगा जो हो जाएगा, is I said it's very easy for you to say it. I said if God takes you away, I said your problem is solved and you're done. I said, God forbid, he doesn't take you away and he keeps you on the bed with all of us. I said, it's not a very pleasant life you're going to look at, because on today's date, medical science has frankly advanced enough to prevent death. But we've still not learned how to give life very easily. Transplant is only one of those places where we are able to give life to a person who's, an opportunity at life to a person. But overall, a sick person, we can prevent him from dying, but very often we are not able to give him the life that he might be seeking. So that recklessness is actually a little humorous way of people to kind of, cover their, what should we say, denial mode in a way, because it sounds good, it sounds bindas, it feels nice to say it that way. But unfortunately, when they repeat it, they start believing it. And my only request very often is amongst friends and stuff, when somebody does do that, is let them be for the moment, because they obviously have a point to prove about how they are. But over time, do express and share with people that staying off the bed is going to work for you, because to see a friend ill today hurts a lot. And I've come to the age now where we are seeing our own colleagues who are hitting hospitals and getting into situations. So we are no more away from that age where disease strikes often. And we realized that it hurts your near and dear ones as much as it hurts you. And I think people need to start taking responsibility for not just themselves and the people around them. And if that doesn't motivate them, then I wish them fun through the recklessness. And I wish for them not to run into a problem.
Okay.
Thank you.
Thank you very much.
We inflict upon ourselves.
Yeah, the other thing I would like you to know is like diabetes is probably the biggest killer. So if there's one single word that you'd like to, push in terms of when we speak to people is diabetes doesn't affect people just because it's a high blood sugar, mithai nahi khana hai, kind of thing. It's a progressive disease. Sometimes your pancreas starts getting more and more insufficient in giving out the insulin to it, and it affects multiple organs, right? It affects the brain, it affects the heart, it affects your blood vasculature, your neuropathy happens with that, your kidneys are hit right away, your eyes are affected, and even the diabetic foot, it's like a single specialty of its own, right? And in fact, when people reach me with the diabetic foot problem, I normally tell them reaching a surgeon with a diabetic foot issue is actually a late situation. We are only doing correctives now. The ideal situation is to control the diabetes at the earliest stage of, itself, and keep yourselves on check so that that prevents you from damaging further organs. So that's one thing that I'd like to take home, that this is one big disease that we as Indians, especially who are genetically prone, also need to be very careful of.
Okay, thank you. Thank you very much, Rotarian Professor Dr. Sudhir Saran. Now, next question, who wants to ask, please unmute yourself and raise your hand. So I will immediately come to you. That is, okay. I think they are taking time. You have explained in such a beautifully that people have understood more. You have mentioned about the medicines over the counter which people are taking in India, but it is everywhere in the world. You can take those OTCs which you are mentioning, like Brufen, etc., are available. If they are so harmful for the organs, why the government is not banning them? Although in India, you can take even an antibiotic or latest medicines without prescription, you know very well. What you think should be the right course so that at least those who are suffering from kidney or other organs failure because of the misuse of those medicines can be stopped.
So I guess what you said in your last few words of your sentence, the misuse, I think it's never the use of these medications which is a problem. It's about misuse of medication. And sometimes if we have to look at slightly longer term usage, we must be aware about its effects on the body. We must be able to monitor what's happening. And if somebody needs to take something like a diclofenac over a long time, I hope it is under physician supervision so that at least they're being checked on off and on. I would like to just anecdotally tell you also that I still remember way back when I was an associate surgeon at Bombay Hospital, probably more than 20 odd years back. There was one gentleman who'd come from Dubai, and this person was obese. So he obviously had other issues with him, diabetes and other stuff. But he was a relatively young, non clinically diagnosed unhealthy in terms of blood tests and all. But he showed up over there in acute renal failure, and the only history of drug intake that we were able to pick up from him at that time was having had 2 tablets of diclofenac, which goes by various brand names. And so it has the potential of creating acute renal failure to that extent. And so we must be, and obviously he must have had underlying weak kidneys because of his, other issues and things, and obesity was going to have so many other issues with it. But we need to understand that these are dangerous medications. Every medication is dangerous, frankly, for that matter, when misused. I think, but the use is very common. What's important for me is like as a doctor, I get so many samples which is placed on my table. And the smallest headache, I can just probably pop in a diclofenac because it might be easiest available. But the question is to understand where we need it, where we don't, and put those things away. And this is an easy go-to. And there are safer options if people need chronic, management of pain. And I think they must reach out to their physicians to be able to, make them choose the right medication for themselves.
Okay, thank you very much. I can see 2 hands up. So I will go first for the person who is owning a pharmaceutical company because we are talking about the medicine only. Rotarian Rajesh Gurani, please ask your question.
Yes. Dr. Goel, thank you so much for the enlightening this thing. So most of the things are very, very clear to all. Like you said, diabetes affects all the organs. So this is, I just wanted you to elaborate upon, you said diabetes drives fatty liver disease also, MASLD.
That's
So
right.
could you elaborate? I want to get know more about it.
All right. So a couple of things. So when we talk about liver disease and people who require liver transplant, typically it is those people who suffer from cirrhosis of the liver who require the transplant because that's a failing liver, or in fewer conditions, an acute liver failure, right? But most of the time, it's a chronic liver failure in the form of cirrhosis who are on the transplant lists. Now, alcohol has been one of the most common causes of cirrhosis. But even non-alcoholic people or people who probably not even tasted alcohol do get cirrhosis of the liver. And at point, this was called non-alcoholic fatty liver disease. Very often, most of the people in our population must have seen in the ultrasound reports a thing called fatty liver, right? So this is basically the deposition of extra fat in the liver, and then slowly, steadily, it moves to the various grades of fatty liver and moves towards fibrosis. Now, fibrosis is basically those hard fibers which don't get replaced, they're non-regenerative, and they create this little hard nodule out of the liver as opposed to the soft, supple tissue which is creating bile for you, right? And once it creates that cirrhotic liver, that liver becomes almost non-functional. Neither does it allow proper flow, neither does it have proper functioning. And the liver is one of the most metabolically active organs of your body, right? And so that's the part where and diabetes has a very, very high role to play in that. So diabetes, hypercholesterolemia, so all these things which cause these have a very direct effect on causing what we call as MSALD right now, which is it's which defines it more as a metabolic disease as opposed to just a non-alcohol related disease. And here is where a little surgeon's role comes in, because today, with the advance of bariatric surgery in controlling both obesity and type 2 diabetes, we do land up with a lot of advantage towards liver strain as well, which is the next organ which is awaiting disturbance in those situations.
Okay. Thank you very much, Rotarian Rajesh Gurhani. Now, next question is from Rotarian Professor Dr. Lakshmi Goel from Morocco.
Hello, good evening.
Hi, good evening.
For that excellent presentation. I have a question that kind of piggybacks on Dr. Sharan's question earlier, and it's about lifestyle and life choices. I mean, it seems like the lifestyle of people is causing chronic conditions to appear earlier in one's lifespan. And yet, just the way we go about life, I mean, our prefrontal cortex is not developed until the mid-20s. We're not really making rational decisions about anything, let alone about our organs. And then we have, significant stress in terms of building career, and so priorities are very different. So by the time one comes around to annual monitoring of metrics related to these things, it's probably too late. So how does one go about, raising awareness that this is a lifelong thing and this isn't something you push, until when you're a senior citizen or approaching, retirement? How do you make these kind of interventions earlier in life?
Right. I think that's a fantastic thing, Dr. Lakshmi. It's a really good thing to pull up because you're right. I mean, when we're looking at lifestyle modification, we need to start really early. By 25, I'm already adamant. I already know more than everybody else. In fact, I think I knew more than everybody else when I was 13. And so I guess these lifestyle habits need to get formed more in the children by their parents, and where they make those choices. Like I have two kids, one of them actually goes to pick up the fruit first, and the other one tends to pick up exactly what I pick up, fast food, right? So one of them is more like the mother, one's more like the father. The mother is doing her best to make sure the best food is on the table. And I think that's probably what really changes their way of looking at it. Secondly, is when something runs, I mean, like these kind of issues, lifestyle related diseases, which we talk about in terms of obesity and diabetes and stuff like that, it tends to become a family, what should we call it, legacy that we tend to pass on because we are okay with it very often, and we allow that to happen with us. and then you allow that to happen with your children as well. So I guess the most important way for you to kind of control that is one, self, obviously, but the children are the best people made aware of the situation, and they are very aware. It's just that they probably need that support and that at that time to be able to, understand the importance of the same thing as they go ahead. It's like somebody said obesity runs in my family, and then there was a joke that no, actually obesity doesn't run in your family. The issue is nobody runs in your family, right? Right. And so those habits need to start early, and it's very difficult to get people onto the sports table at the age of 40. You need to start much earlier. And your question is actually perfectly pointed there, that when do we start making these changes in habits? We start making it when the kids are small.
Okay. Thank you very much, Rotarian Professor Dr. Lakshmi Goel, for your question. What she said, and I just add on this, it means that the parenting is to be changed as per the time now, and the parent should understand the importance of the prevention of obesity and diabetes on a very early stage. Otherwise, we used to listen, खाते पीते घर के हैं थोड़ा, if somebody is having fat, oh, it's very common in India. Nobody bothers about this. And कुछ थोड़ा मीठा खा लेंगे तो क्या problem होगी? And there was an ad, very famous ad, कोई भी anything कुछ मीठा हो जाए. So do you think that we have to change those things now in India, especially the parenting, as Professor Lakshmi has mentioned, that when one person come to know, then it's too late initially. But the problem is the Gen Z or Gen Alpha or Gen Beta, how to change them, how to educate them is also a very challenging thing. Our top people are not even able to control. So how the parents will be able to control, that is a very big challenge. But yes, you are right that if we have to save the organs, we have to be very, very careful from the childhood of a child, so that he or she should not be in the trap for the organ failure. Thank you very much. Now I have a question from Rotarian PHF, Dr. Rohan S. Moniz, who is the Administrative Director at private medical college, Kanchor Medical College in Mangalore. Yes, Doctor.
Thank you, Goel ji. Good evening, Dr. Gautam. Thank you for that beautiful lucid talk. It really helps. Well, it just took me back in time. I was formerly working as an intensivist at Apollo Health City, Hyderabad. And I was in the Department of Neurocritical Care. वहाँ पर देखने से क्या पता चला, like, you have patients coming in who are having metabolic issues, diabetic issues, ये वो, COPD, etc. And we're pumping in omega-3 fatty acids, we're pumping in trace elements, we're pumping in all the healthy stuff. Then I started actually going back in time and saying that, when did I do good for myself? So we end up eating seafood. Seafood means not SEA, SEE. When we see, we eat. And unfortunately, our medical school teachers also didn't teach us, the importance of nutrition when we had. That is the second part of my story. But the first part was this one. So then I got into the preventive aspect of it, telling people how prevention brings about a total 360-degree change in our lives. But during those sessions, Dr. Gautam, the counseling sessions, I realized that our Indian diaspora is basically very reactive and not responsive. They're like, आज नहीं करते हैं, कल शुरू करते हैं, परसों करते हैं, उसके बाद देखें, नहीं आज शूज नहीं मिले, बारिश हो रही थी, रोड पे कुत्ते आ रहे हैं, you're finding reasons to postpone. That is one aspect of my question, like, because this has been a chronic disease, chronic issue. Government is focusing more on communicable diseases and rather on non-communicable also, but not as much as communicable. Secondly, for us doctors or for us healthcare providers, what is happening is, I think the entire medical system doesn't talk about organ donation. It talks about prevention to a largely small extent because of social and preventive care medicine, and we should know determinants and etc. But all in all, I have not seen, honestly, out of 10 doctors, you'll find maybe one doctor talking about organ donation, prevention, and what to do. The 9 of them are mum and busy with their consultations and getting the things moving on in life. I think these are two different aspects, but how could we do it on a land scale, change? I mean, we are here to bring about a change in the community, and we have voices, we have people who talk beautiful stuff, but things should happen from the foundation level. Thank you, Gautam, sir.
Dr. You've actually hit the, in fact, this is something I needed to pull up. And we do create a lot of organ donation awareness in public itself. But I'm not very proud to say this, but let me tell you, even as a medical, if we look at ours as a different subset of the same population, we are probably equally unaware of the processes, about the benefits, about what to do when we have a patient who has an organ which can be retrieved for the benefit of somebody else. So unless we've noticed that unless it is a tertiary institute which is dealing in organ transplant, right, whether it's part of their game plan in terms of the treatment they provide, most institutes where they don't have a transplant program of their own do not even recognize a brain death to be informed to people, and even giving the patient's relative a chance or a choice to even consider the possibility of donating those organs. And I do not put this on to anybody else other than to us doctors themselves, and probably as an intensivist, Rohan's been sensitive about it, but not very many intensivists are sensitive about it because they don't have a system to back them up either. So I know this for sure. Like, I was a new consultant. By then I was aware of organ donation thanks to my exposure within the family itself. But then I worked in other hospitals which didn't do transplant work at that time. And there were one or two occasions where I had patients who came out of trauma and they were in a situation where he was young, things were fine. And I can actually tell you there were 3 instances of that types, which I had in two in the same hospital and one in another hospital where transplant programs weren't in. But when I even discussed with the relatives, that was one part of the thing because that needs sensitization over years. I also realized, let me figure out that if they say yes to me, what is my next step? And there was every person I spoke to within that hospital was one unaware, partly apathetic about the entire situation because it was a system they'd need to create. So the need to change and to need to take those steps was very difficult, to the point of then reaching out to another hospital where the transplant program was on to ask them, do you have somebody who can come and speak to this person here and help them take it through from here? In terms of that was such a big deal for us to do. And this is not then, this is probably 10 years beyond the point where my mother was working as a transplant coordinator, so there was a lot of time that had gone through. But even today, I know if I knock doors on a couple of the hospitals that I work in, they would be lost uh, as opposed to be aware of that situation. So we need to run this program more within the medical fraternity than outside of it, is what my personal feeling is. And or we need to run it equally strongly on both sides. So we must look at organ donation awareness about what are the procedures involved, who do we choose to be organ donors. It might form great MCQ questions, people know about it, but the genuine awareness of remembering it at that time is the most important thing when your patient is actually at a point of brain death. But you have that possibility. So sensitizing people around and figuring out a system in place is what's important. 10 years back, they struggled that they had a person ready to donate the organ, they had the transplant team available. They struggled with systems outside the hospital, in terms of the police was like wondering what's happening. Today, the police don't wonder what's happening. They probably have a protocol in place over there. But they were struggling with those systems. Today, I think they're struggling within our own systems. One, to identify a brain dead person as being a potential organ donor, keeping people, aware about the fact that their organs can be donated. And then I think it needs to start with the medical fraternity itself. I think the hospitals themselves need to sensitize that and give those options to people.
Okay.
Thank you.
Thank you very much, Rotary and PHF, Dr. Johannes Moniz. Dr. Goel, you have mentioned that in the hospitals, it's very difficult. It's not, at that time, it was difficult to disclose or diagnose or declare the brain death. But today, even today in India, as per the NOTO's report, only 16 or 17% of the district headquarters are having the organ retrieval centers. It means there are no brain death declaration committee. It means the majority of the population, I must say the majority of the population is suffering, or their organs are going waste because of this reason. So I only to blame the doctors. I think the blame lies with us, the civil society, the government, or the NGOs, that we are not doing that much ho-halla or raising that awareness that it reaches to the policymakers' ears so that they can change the policies and see to it that every district headquarter should have the this brain death declaration committee as well as the retrieval center. At least in one district or one headquarter, they should have this. Don't you think that is because I'm asking you apart as a surgeon, but you because you are involved in the district organ donation committee as a director also, that what as a Rotarian, as a Rotarian, are we not doing anything? I don't think that the Rotarians are also doing in this field. They are thinking or they are doing anything to create the at least one retrieval center in those areas. Although I know that our district 3141, which is of Mumbai having sufficient number of transplant centers, organ retrieval center. But see the situation of Dhanu, which is also in the 3141 or Palghar. Now, if any accident occurs that side, what is the fate of those organs? All waste, because nobody will bring you the patient to Mumbai to get the organs retrieved and take the body back to Dhanu for the burial. What you say about this, Dr. Goel?
So these are situations. So frankly, what I was talking about probably meant more for in places where we are equipped, right? So Bombay is equipped. We should not be complaining about anything. So as a city of Bombay, we have alternatives, we have options. If not within one hospital, you have the next one, which is probably, less than 1.5 kilometers, 2 kilometers away. So we must learn to exercise those options. But when you're talking about places which are a little further away, like Palgad and other places which are less urban. I think the issue also comes in the form of having a transplant team availability in the vicinity, which is a skill set requirement. In fact, even if you say even amongst urologists, I have a urologist colleague who's only an organ a donor retrieval process is what he's doing. It's actually specialized to that extent, and these teams need to be available in those places also. The places which are close enough to come to Bombay, I mean, there should be something which we can create awareness over there, because we have seen earlier that they've created green corridors and, people have managed to drive through in quick time, and you have helicopters and all of that. But yes, these are all resource heavy situations. This requires a lot of sensitization in terms of their local government as well. And I think it's a process which we need to get started, because 10 years down the line, when this world becomes even smaller and access through things like your coastal roads and even through your airports and availability of those things improves, I see no reason why somebody in a smaller town with a proper hospital setup should lack the need for, or the lack the ability of being able to donate his organs, because we can always fly in a team from somewhere and get those things back again.
No, but Dr. Goel, the fact is that because there is no approved retrieval center, and without the licensed retrieval center, no one is allowed to retrieve an organ anywhere in India. It's a totally
Right. Agreed.
a criminal thing in India. So, and as you mentioned about the green corridor will be always made after the retrieval of the organs for the transplant of transportation of organs, not before that. And that is why this is required very badly, that we must have that infrastructure. Then only the awareness in the rest of the country is of any use. Otherwise, it's like bhais ke aage been bajana wala mamla hai.
I agree with you.
What we are doing, Mumbai, when we talk about Mumbai, Delhi, Chennai, Bangalore, the traffic moves in a very, very slow speed.
Yeah.
How there is a person with an accident, have a brain death, they may have some fracture or something, but not to the extent of brain death. What is happening in highways? And there are no such facilities. Don't you think we must have first priority to get the infrastructure in place? Then only the awareness should come up.
So I agree with you on this totally. So I will actually take it 2 steps further. When we actually look at it, so I think we are still struggling with one is, transporting our injured or a diseased person from their home base or wherever on the roads they've had an accident or illness towards a center which can actually handle their illness. So number one is we need to save that life, number one. So that's priority one. We are still struggling with that. So I think what we need to focus on is in saving that life as much. And once we are able to save lives like that, then we know that the infrastructure has built up to a point where we might now be able to save a life beyond when we can't save theirs. So I guess healthcare by itself, tertiary setups in smaller areas also will slowly need to build up. Healthcare is accessible to many in the urban areas, but the rural areas don't even have a fairly comfortable primary healthcare setup. In fact, it's you could use a post office in Bombay, and you might actually have better facilities, medical facilities in the post office than in a rural healthcare unit, because यहाँ पे बत्ती तो चल रही है, वहाँ पे तो बत्ती भी नहीं होती, right? And so that's the situation we are in. So yes, I think first we need to create access to healthcare to people. Organ donation and organ retrieval, according to me, becomes a very late discussion in those areas, because वहाँ पे तो लोग अपनी जान नहीं बचा पा रहे, वो दूसरे की कैसे सोचें. So they are at a point where they've lost their family for lack of a presence of a doctor who may be qualified, lack of facilities or injections that could have saved their lives. So I guess we need to first work on the primary and secondary healthcare, move towards creating a tertiary setup in those places, and then look at converting those tertiary centers into retrieval centers in that zone.
Okay, thank you very much. Anyone else wants to ask the question? Please raise your hand if any question is there. I think Dr. Goel has given many replies to all the questions which has been raised. There are so many issues which definitely we could, because he is on the same avenue where I am, we will be discussing in the meeting which we are going to have on 30th, most likely, if you are attending that. And we will discuss that how the Rotary can play an important role to see that those areas which are unrepresented, where there are no such type of facilities, can be started with the help of Rotary as well as with the government and other agencies. So thank you very much. This is all from my side. Over to you, Legal Secretary.
Thank you so much, Founder and Charter President, to conduct the question and answer round. And thank you so much, Dr. Gautam Goel, for answering all the questions so patiently and giving us your valuable time. I now request Rotarian Rajesh Gurani, our Vocational Director, Rotary Club of Organ Donation International, to please give the vote of thanks.
Yeah. Thanks, Madam, for the opportunity. Thank you, Dr. Gautam Goel, for your insightful and informative, make it very easy to understand for each one of us. And into details, talking about NSAID usage, blood pressure, kidney, gallbladder, diabetic food, diabetes, veins, and antibiotic uses also, which is something that inspired me. One of your sentence that you started with, your mother, transplant coordinator, and a dinner time discussion that inspired you. I think we are also working on the time will come. It will become, organ donation will become a household discussion. We will surely do this. Thank you very much once again. Thank you all the Rotarians for sparing your time on Sunday evening. Thank you so much. Thank you, man.
Thank you very much. Thank you. It's been a pleasure having addressed you all. And thank you so much for being a part of this movement.
Thank you, Dr. Gautam.
Thank you.
Thank you. Thank you so much, Rotarian Rajesh Gurani ji, for your informative vote of thanks. और सभी YouTube viewers जो देखते हैं हमारा लाइव, उन सबका बहुत-बहुत धन्यवाद ज्वाइन करने के लिए, और सभी Rotarians का बहुत-बहुत धन्यवाद. Over to you, President. Please unmute yourself.
Thank you very much for attending the meeting. Thereby, meeting is adjourned.